We have with us Dr. Sajith Narayan. Dr. Sajith Narayan is a senior consultant nephrologist at the Astor Malabar Institute of Medical Sciences in Calicut. Dr. Narayan did his MD and DM in nephrology from PGI Chandigarh, and after that he has gone and set up this extremely successful and futuristic hemodialysis unit at Calicut. And I would suggest that if any of you are ever there in that area, you should go and look it up. Dr. Narayan gave a presentation on the recent advances in dialysis in the recently concluded Indian Society of Nephrology annual meeting at Mumbai, and it was extremely well received, and there were lots of questions, so we thought it would be a good idea for the new postgraduates to hear this, because many of these questions might be asked by one of your examiners who might have read one of those papers. So without much ado, I will invite Dr. Narayan to start his presentation and tell us about what is hot, trends in dialysis. Dr. Narayan, please.
Hello. Hello, everybody.
Please go ahead, Sajith.
Yeah. So the topic for today is what is hot, recent trends in dialysis. What I've done in this is that I've looked at recent literature in dialysis over the last year or so, and I've selected a few articles which I've felt would are breaking in some way, give us some information about what are the emerging trends in dialysis, and I would be reviewing those papers. So the structure of the talk will be in this form. I'll initially be speaking about acute kidney injury. Over the last couple of years, most of the data in acute kidney injury and most of the recent papers which have been published revolve around timing of dialysis initiation. And I think in 2016, close to each other, we had papers. One is the acute trial, which was published in the New England Journal of Medicine, and the other is the Align trial, which was published in JAMA. I'll be reviewing those two trials. Both were in some way contradictory to each other, and there's a debate in the Society of Nephrology as well about the two trials. And then I will be speaking about pre-dialysis care, about how do you choose your dialysis modality, and about the importance of residual kidney function during initiation of dialysis in hemodialysis, about what is known as an incremental approach to initiation of dialysis, about the concept of dialysis adequacy, which for a long time has been pegged at KT by V, and there's a lot of data which seems to be emerging that we have to look at dialysis adequacy beyond KT by V, and some papers regarding that were published last year. And the last thing is, in a third world country, I think you have to seriously think of cost factor and how we can make dialysis affordable in third world countries. So I'm touching about, since it's a vast area, I'll be touching about each one of these topics briefly only, and at the end of the session, we'll have a question and answer. So to the timing of dialysis initiation in acute kidney injury, this was a paper which was published in JAMA, which was Align et al., which sort of looked at patients who were predominantly, this was surgical cohort, 8% of these patients were post-surgical, half of them were post-KBG, and they looked at 230 patients who were randomized to either early, which was basically acute kidney injury, stage 2, or late, which was acute kidney injury, stage 3, which is predominantly a surgical cohort. I think there's an error there. It's not 80% post-CABG. 80% was surgical, and half of that was post-CABG. And it was a universal CRRT. All patients were subjected to CRRT. And the early was AKI2, late was AKI3, or specific indications for dialysis. And this study showed that in the early group, they had a lower mortality rate compared to the late group, and with a hazard ratio of 0.66, even though the confidence interval is fairly wide, you must see almost goes up to as much as 0.97, which seems to tell you that it's spread out. So I would personally be a bit skeptical when the confidence interval reaches close to 1, because it means that it is spread out over a large population, over a large number. But then the outcome is that statistically significant outcome was that doing an early dialysis in this cohort of patients seems to have a lower mortality. And this was a study, this was a 90-day follow-up study. At 90 days, they looked at survival, and they showed that 90 days there is a lower mortality if you dialyze patients early. It was like earlier, it was all CRRT cohort. Paradoxically, around the same time, New England Journal of Medicine, you had this Akiki trial, which was a multi-center trial. And this is a slide which tells you the difference between the two trials, which I think is important in the context when you interpret these trials, you should know. And Akiki trial, for example, was a large multi-center trial which had recruited 620 patients. Align was a single-center trial. It had recruited 231 patients. In the Akiki trial, which recruited a mixed patient population, predominantly medical, 70-75% of the patients were medical patients. Sepsis was the commonest medical disease, whereas the surgical cohort was lower, whereas Align trial was 80% surgical, and in that you had liver transplant, you had gastro-intestinal, but half of the entire cohort was post-CAPG. The modality of RRT used in Akiki was hemodialysis. I have not distinguished between SLED and conventional hemodialysis. Around 20 to 30% of patients were subjected to CRRT, whereas Align, the protocol itself was that in the first week, it was CVVHD by default, and at the end of first week, they either continued CVHD or shifted to intermittent hemodialysis. Akiki, stage 3 was considered early, whereas in Align, stage 2 plus one major comorbidity could have been sepsis requiring noradrenaline support or worsening related parameters. One major comorbidity and stage 2 acute kidney injury was sufficient for them to go into the early group. And in Akiki, the late group was always specific indications, like pulmonary edema or hyperkalemia or acidosis or encephalopathy. Whereas in Align, stage 3 automatically became late group. The difference, two trials were structured very differently. They had a different patient cohort and they had different methods of delivering RRT. So in the Akiki trial, unlike in the Align trial, it was a extended follow-up, and it was found that doing dialysis early or late, you had no different survival. In the Akiki trial, around half the patients in the delayed group actually got away without dialysis compared to the early group. However, that did not change mortality or outcome in any way. There was also, in the Akiki trial, obviously, there were lower infection rates also because you were using lesser catheters and lower infection rates in the delayed group. So if you look at these two trials, you're seeing two trials with different outcomes, but then I think at the end of the day, they are different trials, they are different criteria, there are different clinical scenarios and different study designs, and modalities used are different. We should not, I personally think the jury on this is not yet out, and I would personally feel that the Akiki trial represents a more heterogeneous population, being a larger study, a more multi-center study. And I think the difference in dialysis modality as well as the kind of patient population you see in Align, which is like a predominant surgical cohort, very hypercatabolic, you're using CRRT where you maybe have to use it very early. And therefore, I think when you choose acute kidney injury patients into dialysis, it is based on your clinical judgment rather than based on any study. As of now, there seems to be evidence, seems to suggest that in patients, you can wait till a specific indication arises. Coming to the CKD studies, we know that in India and most of the countries in the world, CKD stage 5 going on to dialysis by default is hemodialysis, and peritoneal dialysis is usually an exception. Actual cost, in terms of actual cost, this was studied, I think, with Jalokia. I don't know how many of you have read this paper, which came in ISN a few years back, where at an actual level, he tried comparing the cost of hemodialysis and CKD, and his convention was the cost is the same. So the actual cost is similar. However, there have been government schemes supporting hemodialysis in lots of states, and standalone centers which are run by charitable societies has heavily tilted the balance in favor of hemodialysis in the country. So a lot of hospitals and a lot of government hospitals and a lot of charitable centers providing free hemodialysis. And therefore, the incidence of CAPD as well as the overall prevalence of CAPD in our country, I think over the last few years is really going down. At least in my practice and what I've seen around here in North Carolina, hemodialysis really boomed a lot, but CAPD has remained where it was 5 years ago. And we know the last budget, the finance minister did about dialysis mission and start taking dialysis to the community and starting small dialysis doesn't look at district hospitals and all that. But I've largely, the government has also focused on hemodialysis rather than PD. The role of PD in the overall setting scenario is as of now still uncertain. And let's face it, at the end of the day, there is all of us work for incentives, and hemodialysis, there's a lot of incentive for doctors, unfortunately. There is, and this was another factor which was studied in the United States, where the concept of incentivizing hemodialysis was changed recently, and they have incentivized hemodialysis to the bundling pattern was changed, and the incidence of CPD in the US in the last 2 or 3 years after the incentivization was changed has significantly risen. So it is not like doctors are immune to incentives, and it seems that since lack of incentive is also a factor which pushes PD to the back burner. And I think at the end of the day, the kind of population we have and the kind of numbers we have, I think at the end of the day, it is just stop restricting yourself to one dialysis modality will be foolhardy. I think in the kind of numbers, I think we'll have to marry both. We'll have both a good maintenance modality program across the country, and we also will need a good CAPT network. Otherwise, I don't think the numbers will be able to meet the numbers. So this was a study which looked at PD, and it was a sort of study which looked at a scenario where cost is the same. It's cost neutral, and they sort of looked at this meta-analysis which looked at what sort of patient education program you need to choose CAPT rather than hemodialysis. It's basically what's known as a PD first program, and they looked at structured patient targeted education intervention, and they found that this meta-analysis which had one randomized controlled trial and several smaller non-randomized trials, that what they found in studies which use group education, that is, you get all the patients in one place and you educate them. Use an educator who is a nurse rather than a doctor, because doctors usually don't have time, and I don't know, you don't really spend much time speaking about these things to the patients. You have an educator who is a nurse. But 2 sessions, one session now, and then you get back to the patient, call back to the patient. We use a lot of video aids, and most importantly, you incorporate patient feedbacks from patients who are on peritoneal dialysis. You get your patient who's planning for PD to meet the patient who's on peritoneal dialysis, and you incorporate all that, and it's found that this patient-targeted education is odds ratio is very high here, and most of the even randomized trial as well as in the observational studies, most of them have shown that we have patient-targeted education using multiple sittings and using patient feedback. You have more patients choosing peritoneal dialysis rather than hemodialysis. Let's assume that the patient has, rather than choosing peritoneal dialysis, opted for hemodialysis, and you would like to create an AV fistula for him. We all know that in AV fistula, the commonest modality is a radial AV fistula. If otherwise you go for brachial AV fistula, and more often than not, fistulas are done under local anesthesia. This was an interesting trial which was published in the Lancet, which looked at a simple anesthetic modality of brachial block upper local anesthesia to see whether the difference in outcome in terms of fistula patency. What I have seen in practice is that a brachial block does help in terms of making the veins in the upper limb prominent. And there have been situations where you don't get the radial vein much. You use a brachial block and the radial vein becomes prominent because of the venodilatation. And previously planned brachial AV fistula tends to migrate lower down. So that has been well described, and that a brachial block does facilitate surgical ease. But this was a trial which looked at patency rates. It looked at patency rate at 3 months, both immediate patency rate and functional patency rates. And it found that in terms of both radiocephalic as well as brachial functional as well as primary patency was superior in patients who used a block compared to patients, sorry about that, when compared to patients in whom you sort of use only a local anesthetic. So that seems to be a case, especially I think in multiple patients, there seems to be a case to do an AV fistula under a block. You need more evidence and has to accumulate on this. But a brachial block is not a very difficult procedure, and most of the surgeons who are doing AV fistula can give the block themselves. Personally, in the hospital where I work, my surgeon does the block himself. He doesn't require an anesthetist for that. Anyway, another option which you have if you don't have vein is to use an AV graft. The problem with AV graft, like most of us know, there are multiple problems. It's only in situations where failed fistula access is the only thing you have. The problems are that you have intimal hyperplasia, the anastomotic site, which leads to stenosis and thrombosis. You can have infection, and you can have focal dilatation, aneurysmal dilatation, and sometimes even rupture of the AV graft, because at the end of the day, it's a synthetic material. So you have several biological alternatives which have been used over the last several years. We have the bovine carotid artery, which has been tried. The cryopreserved human vein, as well as a variety of autologous conduits. This was a trial which was published again in Lancet, which sort of used what is known as a bioengineered acellular dialysis access. Where what they've done is that they've taken a scaffold on which is actually a sort of artificial material on which they have the stem cells. They have allowed the stem cells to go on the scaffold, and then they have created a bioengineered vessel, and after that they have decellularized and removed all the cells. So what you're left with is only the collagen, because they are against an artificial scaffold. And it's an acellular vessel. The reason why they decellularize is that obviously if you have a human cells sitting there, you will mount an immunological reaction. So the thing is, you're trying to make a conduit which is out of natural material, but at the same time which does not have any cells on it. And the belief was that if you use this and you create a heavy graft, you would be able to have higher latency rate because you are using what is more physiological. So they have undergone phase 1 and phase 2 trials. This is the phase 3 trial, which looked at almost 500 to 700 patient days of follow-up. Looked at both primary and secondary patency rate, primary assisted patency rate also, which means that basically you are doing an intervention to keep the graft patent. So the outcome in this trial was at the end of approximately 6 months of follow-up was that the thrombosis rates were actually not any different, which is a bit disappointing because one of the things they expected was that this would be less thrombogenic. And the need for intervention was also, when compared to the conventional PTFE, was often different. But what was very different was the infection rate. The infection rate was remarkably less in the acellular graft when compared to PTFE. Another thing which they've noted was that the incidence of aneurysm formation, which is common at the cannulation site, by the end of 1 year or 2 years, most of the PTFE grafts at the cannulation site tend to become aneurysmically dilated, and that incidence was also very less in the acellular synthetic graft when compared to the PTFE graft. Of course, they are looking at more trials, larger trials in this before we really will know this will become available. But it seems to be at least a more practical alternative to a PTFE graft. Coming to somebody whom you are initiating hemodialysis, we all know that the concept of residual kidney function has major implications in CAPD. It's an integral part of the CAPD prescription. In fact, most of the advantages which CAPD gives in the early period, to a large extent, is because of the good residual kidney function is there in CAPD, and we have seen a lot of literature that residual kidney function in CAPD, preserving that has multiple benefits in terms of fluid balance, in terms of phosphorus balance, etc. Unfortunately, in hemodialysis, we don't really give much importance to residual kidney function. And it's a myth that in hemodialysis patients, residual kidney function is lost at a much faster pace when compared to PD. But there is some evidence now that this residual kidney function in hemodialysis is almost similar. The rate of loss of residual kidney function in hemodialysis is almost similar in comparison to peritoneal dialysis, especially with current sort of bicarbonate buffer standard bioincompatible membranes. So this was a study which looked at what happens when you lose your residual kidney function in patients who are initiated on maintenance hemodialysis. This was actually a longitudinal cohort of 6,000 plus patients, which was published in JASN last year. And this was over a 4-year period. They collected both urine output as well as urea clearance. They looked at baseline at 1 year and really tried to correlate death with residual renal function. And what they found was fairly surprising, because they found that even in patients on twice-weekly maintenance hemodialysis, having some sort of a residual kidney function directly correlates with a better outcome. So there's a hazards ratio which looked at what was your urea clearance, residual urea clearance at 1 year, and how do you do. And patients, the higher was your, it's a linear curve, and the higher is your residual urea clearance, or lower is the risk of death. So you cut off this at 1, and you can see that patients who have a residual urea clearance of 6 ml per minute or more do better than patients who have virtually very little urea clearance, which is less than 1.5 ml per minute. Your mortality rate is around 1.5 to 2 times. So they looked at this, and they also looked at urine volume. And the same thing again, if you're good urine output, 1,200 ml or more, your mortality is almost lower than 1. This, and if urine output at 1 year, which is less than 300 ml, you're 1.5 to 2 times higher risk of death when compared to patients who have urine output of 6,200 ml. So basically, both in terms of urine output as well as in terms of urea clearance, there seems to be evidence that even in thrice-weekly maintenance hemodialysis cohorts, the kidney has something to contribute. So this was what they looked at in terms of uh, yeah, in terms of other comorbidities, and they found that adjusted for all comorbidity, whether it's congestive heart failure, phosphorus levels, or anything, the rate of decline is not just absolute residual kidney function, was how fast do you lose your urine volume. And they found that patients with a fall in urine volume more than 600 ml per day over the baseline, at the end of 1 year, if the drop has been more than 600 ml, they had a higher mortality. So what are the strategies you can use? So this was the thing, that if you know residual kidney function is important, then you have to have a strategy to preserve residual kidney function. And what are the strategies which can? The thing which you can do most important, I think, is to be very careful with your ultrafiltration rate. Don't be too aggressive. Avoid intradialytic hypotension. Maybe you can afford to set a target weight which is slightly higher than your dry weight. Limit the fluid removal. And actually, there's not much evidence that most of us do prescribe ARBs with the hope that it helps preserve residual kidney function. The evidence on this is very limited. I could come across only one trial. Hello?
No, that's fine. Now we are seeing the slide.
Any problem?
No, please go ahead.
Yeah. So there's only one trial which looked at ARBs and residual kidney function, and that trial will say that there's not much evidence there. One of the things which we should avoid is continuing to use nephrotoxic drugs in patients who are on dialysis, especially if he has good residual kidney function. This is one of the things we know at PD, that you are having PD peritonitis, should not use amikacin to treat PD peritonitis if the person has residual kidney function, but we don't really practice that at chemo, because there are times when we use aminoglycosides, sometimes even NSAIDs more liberally in hemodialysis patients. But if he has good residual kidney function, there's a case for us to avoid nephrotoxic drugs in patients. And of course, there's some evidence about ultra-pure dialysis fluid, there's online hemodiafiltration, about which I would be going into much, which seems to suggest that these cohort of patients have a better residual kidney function. The use of diuretics, maybe in some situations, and there's some evidence now in the concept which is known as incremental hemodialysis, which is gaining evidence, especially in third world countries. Maybe you can think of a concept known as incremental hemodialysis when you initiate dialysis, which has been shown to preserve residual kidney function. So this was a study which was published in the Kidney International, which looked at treatment frequency and mortality among incident hemodialysis patients in the United States, which compared incremental data with standard or more frequent hemodialysis. They compared with both conventional as well as more frequent. Sorry about that. They looked at, then to understand that the incremental cohort was a very small number. You had 50,000 patients who underwent conventional hemodialysis, but only around 400 patients underwent incremental hemodialysis. And therefore, the incremental cohort is very small in numbers, not even 5% of the total conventional cohort. And they found that in terms of both mortality as well as in terms of adjusted for comorbidities, there's no difference in the two patient arms. In conventional HD, the mortality was 17.8, and incremental HD, the mortality was 17.6. The only thing is that in patients who had high Charlson index, which you can see here, the high Charlson index means you're having a high comorbidity rate. Charlson index is basically a score which captures your comorbidity data, and if you have a high Charlson index, it is preferable to go for more frequent dialysis. But then that doesn't mean that you start everybody on twice weekly dialysis. That's what you must understand. That even in this study, at the end of 1 year, around 1/3 of the patients have migrated to twice weekly hemodialysis. And if you're starting incremental hemodialysis, the recommendation is that you have to be very strict with follow-up, and you have to meet a few sets of criteria before you start incremental hemodialysis. So this was another set of data which suggests that there's no difference in mortality between 2 and 3 times per group, even if you adjust for baseline eGFR. So there's a hypothesis that the observed survival advantage in twice weekly hemodialysis could be because doing the twice weekly hemodialysis in the beginning may preserve baseline kidney function better. But then, so this was a concept which came in that if you do incremental hemodialysis, you can preserve residual kidney function better, and because by preserving residual kidney function better, you can continue doing incremental hemodialysis until the residual kidney function wears out. these were the criteria that has been laid down by this group, which is trying to practice incremental hemodialysis, which says that first you should have good residual kidney function. Other thing is that your interdialytic weight gain should not be very high. It should be not between less than 2.5 kilograms or less than 5% of the ideal body weight. And you should not be going to the pulmonary edema load. Your body size related to residual kidney function should be good and should be suitable, which basically means that the large people, in fact, may do better on twice weekly hemodialysis. You should not be going into recurrent hyperkalemia or hyperphosphatemia, and you should be nutritionally preserved, and your hemoglobin should be responding well to erythropoietin. So basically, and your comorbidities should not be very high, and your quality of life should be good. And this should be maintained on a regular follow-up protocol. And it should not that you do it in the beginning and then you don't follow this up. So doing incremental hemodialysis means that you should be on a regular follow-up, and these criteria should be met on every follow-up. On the other end, now this is another concept which is known as extended hemodialysis, which throws straight in the face opposite of what I was presenting so far, which means that you do more dialysis. I would like to say that these are patients who've been on hemodialysis for a longer time. The concept of incremental hemodialysis is for patients in whom you initiate. These are for patients whom you are maintaining dialysis. So there are two different patient populations. You should appreciate that. So this is extended hours HD, which basically mean your duration of dialysis in this study was for 400 hours per session, and the other one was for 211 minutes, so that's around 3.5 hours per session. So the mortality in the patients who received longer dialysis was almost less than 50% of the mortality in the patients who were receiving conventional hemodialysis. So definitely this study seemed to suggest that in patients whom you are doing extended hours HD, there seems to be better outcome in terms of mortality as well as in morbidity. And this is not the only study. In fact, after this was published, is another study which has come in just last month's journal, and JSN also, which is saying the same thing. So there seems to be a lot of evidence accumulating that doing dialysis for a longer time seems to help patients, especially if you are on long-term maintenance hemodialysis. That's coming to small solute clearance. This was a study which was published in JSN, which relooked at the hemostatic data, which basically did not just look at urea, but showed difference in concentration of different molecules. This was they took the same sample which was there in the hemo study, which looked at the hemo study only looked at KT by urea, but this looked at they collected the same samples and looked at a variety of different solutes, which they found were uremic toxins, some of which were protein bound, some of which were not protein bound. They relooked at the urea also, and what they found is that the difference between the two arms of the hemo study in terms of small solute clearance was not very great. Even the urea reduction in terms of absolute concentration was only 10%. And none of this reduction in concentration was statistically significant. Even though the hemo study itself, there was a 30% reduction in KT by V. But so therefore, they have gone on to say that it's difference in KT by V, which was 30%, but actual difference in small solute clearance was only 10 to 15% in most cases. And maybe KT by V is not a great measure for adequacy. Actually, the original NCDS study which looked at this used KT by V as a measure, and then subsequently everybody have been following it. The problem with KT by V is multiple. One of that is that it focuses only on small molecule clearance, but we know that it's not just small molecules, protein-bound molecules as well as other molecules are also equally important. It does not focus on ultrafiltration at all. It does not focus on quality of life of the patient. The most important thing is this is measured only during one dialysis session. Maybe you're doing a monthly KT by V, you're doing it during one session, and unfortunately the other sessions may not be equally representative. And the timing of sample collection is important. And most importantly, a KT by V, as consistently seen in most studies, it gives you a false sense of competency that you're delivering adequate dialysis, because you can achieve a high KT by V by dialyzing for 3 to 3.5 hours in certain category of patients, especially women and low-weight individuals. And you get into a sense of complacency that I'm giving them adequate dialysis. So it is the same population in who dialysis may be undelivered when you deliver a 4-hour session, because this population maybe will, go up very well, which is what was looked at in this study in Kidney International, which actually looked at KT, but they have used a different denominator. They have not looked at KT adjusted for volume. they have looked at KT adjusted for energy expenditure, because the hypothesis is that at the end of the day, the amount of urea you synthesize is in proportion to the amount of energy you expend. And patients who have a higher energy expenditure will need a larger dialysis when compared to patients who have lower energy expenditure. And they have adjusted KT by for resting energy expenditure, and they found that in patients, when adjusted for that, you are delivering a reduced dialysis dose for women as well as in young individuals. Similarly, they also found that in adjusted for KT by V, it's found that when adjusted for residual energy expenditure, you are delivering lower dialysis in patients who are diabetic and patients who are also frail. Basic hypothesis, a lot of evidence, not just the study, there's a lot of evidence that the denominator of V is where the problem is. Maybe the numerator seems to be fine, but should you really be adjusting KT against V? Because one of the things which I had read in the editorial is that the example when you measure GFR, you are adjusting GFR against body surface area. So similarly, should you be really adjusting KT against V, or should you be adjusting it in some other denominator? And one of the studies which was looking at this is that you do not measure V at all. You only measure KT. This is because this is a study which was published from Spain. It was a multi-center study across Spain. And what they have done is that they measured KT using what's known as ionic dialysis. Ionic dialysis is a method where the dialysis machine itself tells you what the small solute clearance is. The Fresenius machine which they have used in the study, they were able to validate this to measure KT previously. This was published in a previous paper, and they have adjusted this to the body surface area, like what you do when you measure GFR. And they have adjusted KT to body surface area. This was also validated in the previous study. And they have compared this KT to what you do by the conventional method, this KT by V. What they have found is that when compared this, when you KT target is not met in almost 25 to 30% of patients who meet their KT by V target. This is a prospective study, almost 8,000 patients, and they have looked at survival rates against total urea clearance, which is KT. And they found that survival rates in both adjusted for and unadjusted for models, as well as hospitalization rates adjusted for and adjusted for comorbidities, is directly proportional to the total urea clearance, which is measured in basically liters. So the higher the urea clearance in liters, the higher is the lower is the mortality, the lower is the hospitalization rate. And they have made a case, this is basically published by the Spain Society for Dialysis. I don't recollect the exact name for that society. But they have made a case where they said that you should not be measuring KT by V. It's better you just measure total KT, because it's easy to measure. The machine will tell you total KT using ionic dialysis at the end of every session. And you cannot, there's no fallacy of measurement there. So this, that coming to small solute clearance, up to the last, I think I have 10 minutes of the end of my talk, where basically affordable dialysis and the concept regarding affordable dialysis. One of the things which we all know is that dialysis machine over the last few years, they have fine-tuned a little here, a little there, but the concept has been almost the same since the 1950s and 60s. They have been fitted up with LCD screens and all that, but the problem is that they are very expensive. Almost every one of these dialysis machines have depended upon water. When compared to technology and innovation which has happened in other fields, computers have become from the size of a bus to almost a wristwatch. The costs have incrementally gone down. In dialysis machine technology, the costs have only gone up. And therefore, there's been an attempt to see whether you really can have a dialysis machine which runs not on conventional electricity and does not really need an RO plant, whether you can run on solar power and whether you can run on batteries. And this was what is known as an affordable dialysis price, which was launched in 2016, and by the George Institute in Australia, and also this was published in Lancet. This article, the winner of this prize was an engineer from Ireland, Vincent Garvey, and this was his model. This is not a prototype. This is only a model in which he sort of designed a solar panel with which you can make ultra pure water, as well as with which you can create your own PD bag. and the whole thing is portable and doesn't require electricity, does not require high quality water. So I believe that this is going into prototype soon. I think Urja will be in a better position to tell you regarding that, whether the prototype is yet out or it's still in the design phase. So maybe you can, this is one of the models. I mean, you can seriously look at what you can do to decrease the cost of maintenance hemodialysis or PD, because this will what you will need in countries like Africa, and which has no access to water or electricity, as well as remote parts of India. So this is a summary of my talk. I've covered a few topics here and there. I know it's none of which has been very comprehensive, because only trends in dialysis is what I've been asked to talk about. So we have acute kidney injury. When should you start dialysis? I don't really think the jury is out on that yet. I think there's no definite evidence that early dialysis is really needed. You have to go by the clinical scenario, what sort of dialysis modality is available for you, and the nature of the patient. You have to individualize care there. Adoption of CAPD is one area where I think we are really, in India, where we are really very, very backward. And I think you have to really focus on patient education, especially if it becomes a situation where the government is funding both PD and hemodialysis. Still the tendency is to push towards hemodialysis, because I think that's default. Hemodialysis means you just have to tell the patient hemodialysis and everybody will understand. But PD will require a lot more education. And I think, like in the study which I showed, education with caregivers and education with patients who are on PD already will really help patients to choose PD better. But like I said earlier, in India, I think you have to have both. I don't think with the kind of numbers we have, doing only hemodialysis will take care. I think we need to have both hemo and PD. And there's an increasing body of evidence that preserving residual kidney function is important for both modalities of dialysis. And of course, if you're preserving residual kidney function, maybe there is such, given a cohort of patients, you can start off doing only twice weekly dialysis, which I think is a practice which by default most of us do. When you're using KT/V as a modality as a method of measuring dialysis adequacy, it's better that you have to use it with caution, especially like I said earlier, in thin people and women, KT/V targets will be met very fast, but your actually absolute urea clearance is going to be low, because the V here in these people tend to be low, and therefore, your KT/V will go up very fast, but you are actually under dialyzing them. You will see a lot of this in clinical practice. At a personal level, I have seen that thin women are especially extremely difficult to give adequate dialysis. They tend to be uremic very often, in spite of giving twice weekly dialysis, and you may have to give these people longer dialysis sessions to make them come out of uremic symptoms. You tend to be anorexic and go into recurrent pulmonary edema. Alternate models of small solute clearance, like KT adjusted over something else, either KT alone or KT adjusted over body surface area or KT adjusted over energy expenditure, may be a better method of measuring dialysis adequacy. I don't think anybody has come yet with the best possible alternative, but adjusting for V seems to be fraught with risk. In long-term hemodialysis patients, when I mean long-term, I think most of these are patients in whom residual kidney function has been lost. In such category of patients, there's an increasing body of evidence that longer duration of dialysis will have long benefits, both in terms of hospitalization rates as well as in terms of mortality. Alternate dialysis delivery models, low-cost dialysis delivery models is needed across the globe, especially in third world countries. Unfortunately, in our country, if you personally ask me how many of our patients are doing hemodialysis, how many of our patients are doing peritoneal dialysis, we have little or no data. And I think one of the things which was discussed in the last ISN is that we should create a CKD registry. And obviously, if you create a CKD registry in the CKD5 group, you can also enter dialysis population. And maybe we will start having some data from there. Thank you all. I think I've come to the end of my talk. I think Dr. Jha will take over from here.
Thank you very much, Dr. Sajith Narayan, for that excellent presentation and a comprehensive cover of a number of topics which have been appearing in the journals, high quality journals, a range of topics starting from initiation of dialysis and acute kidney injury to vascular access to adequacy of dialysis. I think these issues are extremely perceptive but also extremely relevant in our clinical practice, and I am sure there would be a bunch of questions. So I would suggest that you guys go ahead and think up your questions, and you can use two ways to ask